So this shoulder has been dislocated. It is most common, it was specific to shoulders. This slide is not to show you specifically to shoulders, but specific to shoulders. Shoulders almost always dislocate anteriorly and inferiorly. They always dislocate to the front and down, almost always. They can dislocate posteriorly with enough trauma, and they can dislocate medially. They can actually, with severe enough trauma, the head of the humerus can actually punch through the rib cage. Okay, and actually, it's not very fun for the patient when their shoulder gets stuck in their rib cage. Yeah, so you can see where it's at right now. If it goes much further, it can be forced through the rib cage, and that can happen in really bad traumas, motorcycle accidents, things like that. Dislocations can happen fairly easily, though. Has anyone ever dislocated their shoulder? No? So you know somebody very close to you, seen it happen? Yeah? Parrish, you shook your head yes, pretty like it has happened to you and someone close by you? Sister? Sister's mom?
It screwed back in because it kept popping out.
Wow, so it was repetitive, yeah? Were you with her when it happened any of the times?
No. I've seen her shortly after.
Yeah,
yeah.
Wow. You know, they're in such intense pain when this happens, when any dislocation happens. Just remember the word dislocation means the body part has been removed from its normal location. It's out of place, right? Contrast that term with the term subluxation, okay? Subluxation is when a body part is shifted a little bit away from where it normally is, okay? Such as in the cervical spine here. There is cervical vertebra number 4, cervical vertebra 5, and cervical vertebra 6. If you draw a line down the anterior of the vertebral bodies, that line should meet up with all of the vertebrae. And in this case, cervical vertebra number 5 sits posterior to that line. Ignoring what the cause might be, the patient may have compression of some of their nerves, right? Some of those transverse nerves that exit through these vertebral foramina, as well as the actual spinal cord posterior to the vertebral body. When the vertebral body moves back, the spinal cord may be compressed, causing things like numbness, loss of function to certain parts of the body. But importantly, that's a subluxation. It's a little out of place, but it's not completely out of place. Other terminologies that we'll need for trauma: sprain, as I'm just reading straight from here, forced wrenching or twisting of a joint, resulting in partial rupture or tearing of supporting ligaments. The important part of this term is the term ligament. So, what's a ligament? What do they do?
Ligaments help you basically keep the bone in place. They help you with flexing and...
So I was on board when you told me keeps the bone in place, but they don't help you with movement. Right. Ligaments connect from bones to bones, right? Giving you stable joints, okay? So when ligaments are ruptured or torn, the joint can become unstable, okay? So ligaments are the supporting structures that connect bones to bones and keep the joints stable. Contrast that with tendons, which connect muscles to bones, allowing you to create movements, right? A sprain is a tearing of a ligament, rupturing or tearing of a ligament. Sprains can be just as severe as fractures, which is the next term. Fractures. All right, so from here forward, if you haven't done it already, throw away the word broken bone, okay? There is no such thing, / every fracture is a broken bone, okay? So, I don't know, tell me if you heard this before. The doctor said it wasn't so bad, it's just a fracture, I didn't break it, yeah? Lots of people say that, right? The doctor said I just fractured it, it must mean it's not broken, right? The word fracture means broken. A fracture is any break in a bone, okay? So there is no such thing as I just fractured it, it's not broken. If it's fractured, it's broken. Now what the patient probably thought when they said that is they probably thought it's not broken in half, right? That's what you think of when you think of broken bone, right? That what we would just call a complete fracture. Okay, so every break in a bone is called a fracture. We can throw away the word broken bone and just call them by their different types of fractures that we have, and we'll get to go through these. Contusions. Contusions are a bruising of the skin without a fracture or a break in the bone. A bruise type injury without a fracture or a break in the skin. You may be contused and have a fractured bone, but you won't have any broken skin. Okay, fracture terminology. This is going to do a lot with fractures. That's a lot of what we deal with in traumatic radiography is fracture. So apposition. Apposition is a term relating the relationships of the fracture fragments. So these are both complete fractures, what somebody without training would call a broken bone, right? They're both complete fractures. We have anatomic apposition, where the bones are anatomically aligned. They're opposed to each other, aligned anatomically, how they normally would be. There can be complete lack of apposition, where they don't line up at all. Okay. So that often comes in terms of angulation, which I'll talk about on the next slide. Then there is bayonet apposition. The fracture fragments are separated and drawn across each other. That commonly happens in the femur. It can happen in the humerus as well, but most commonly in the femur, because the bones of our the muscles of our thigh are so large, and in response to trauma, the muscles contract, pulling those bones across each other. So with lack of apposition, that's often due to angulation. The fracture fragment, the fractured piece, becomes angulated in relationship to the length of the rest of the bone. Angulation toward the midline of the body is called Varus Angulation. Angulation away from the midline of the body, the midline is shown as this vertical blue line, is called valgus angulation. Varus and valgus. Those can also be used to describe movements of the foot and ankle as well. Varus and valgus angulation. Okay. So those are some of our terms with alignment. We can say the fracture is angulated. We can describe it as varus or valgus angulation. We can say the fracture fragments are anatomically aligned, or they have no anatomic alignment, and everything in between. You can even describe the degree. You can use it like a protractor. You can describe what is the exact angle of angulation. Okay. So let's look at types of fractures. I'd like to start with these first two, and then change the names. So these first two are labeled as simple and compound. Let's just change those names right now because we don't use those terms any longer. Even though they still are used in the textbook, as far as I can tell, we still use them in our textbook. However, simple fractures, we're going to call them closed. Okay? A closed or simple fracture is any break, any fracture of the bone that does not puncture the skin, okay, leaving the skin intact. A open or compound fracture, open being the more correct term, is any fracture where the fragment penetrates the skin. So bone protrudes through the skin, that's an open fracture. Which is worse? open fractures, right? Why?
Infection.
Yeah, I mean, but you have a mouth and a nose and ears and eyes. You got openings on your body all over the place, right? What's wrong? What's the problem with having an opening in the middle of your leg? Why don't I get infected through my mouth or nose or ears?
Well, we can, but
Sure, I can. I absolutely can, right? Those areas are designed to be open, right? My mouth is designed to be open. I've got all kinds of stuff going on in my mouth and stomach that kills bacteria, right? But the middle of my leg, my lower leg, I don't have anything to help me stop bacteria from getting in. I have my skin that helps stop that, right? But when that skin is broken, any old thing can just get into my body, right? You have bacteria on your skin that's pathogenic. You have Staphylococcus bacteria living on your skin. If that gets inside your body, it causes infection. Okay. As well, whatever caused the fracture might, they fell down a mountain, right? Hiking, they fell down a mountain and they got an open fracture that way. Well, they got some of that mountain inside that fracture, right? So it risks the possibility of causing infection. Much higher likelihood of developing infection with an open fracture. Good. So we don't want those. We're trying to avoid those for sure. What if somebody had, if you had to perform first aid and somebody had an open fracture? Would you like push it back in? What would you do?
Open fracture where, like on their chest? That's what
Oh man, if they got an open fracture on their chest, you better get them to help pretty quick, right? Let's say it's just like this, tib fib on the lower leg.
No, if they're outside like an emergency setting, someone just got hit by a car, somebody broke their leg, I mean, you would still try your best to do CPR, make sure that everything around you is good, safe for you to be able to get into.
Splint them in the position that you find them.
What if you don't have anything? Also,
Make something. Yeah, figure it out. But importantly, when there are open fractures, and in fact, let me just extend that to any type of fracture. The fracture fragments should not be moved by anyone other than the healthcare providers, okay? That means in X-ray, we don't move the fracture fragments around. We don't align anything to like, I think it's obvious, but it might not be to everybody. We don't change the position of anything, right? They're splinted in the position that they're found, right? And then they are radiographed in that same position. Once that radiograph is performed, then they go to emergency surgery and have the body part opened up, have the cavity irrigated out, started on high-dose antibiotics, and then they're closed back up, okay? Aligned to the best of the surgeon's abilities, and then closed back up, and then they have, a dozen surgeries following that to get the body part back together. But the point is, you don't want to change the position, right? Because, importantly, it's not just the bones in there that we're worried about, right? We're worried about the arteries that run right next to the bones. We're worried about the large nerves that, if they become severed, will not work anymore, okay? We're worried about the muscles, and we're worried about the tendons, but importantly, we're worried about those blood vessels and nerve fibers, and we don't want to change what's going on with those, okay? So we just don't want to move anything. So for first aid, think it in your head, splinting them in the position they're found. In the radiographic suite, we're keeping them in that position when we radiograph them. That might mean that you have to modify what you're doing, right? I've taken cross-table laterals of the knee where the knee was pointed at me in AP. Like the knee was facing towards me, but I was shooting across the table laterally, right? Because they'd fractured their femur, and the whole thing, because of the muscles of their leg, twisted 90 degrees, okay? So what you would call a lateral might not be a lateral of that body part, okay? Because with fractures, things tend to change in direction or angulation, and it's important that we keep them in those positions. Simple and compound, or closed and open, which are the more commonly used terms nowadays. Incomplete fractures. Incomplete fractures do not traverse the entire width of the diaphysis of the bone. So the length of the bone, the shaft of the bone, can be referred to as the diaphysis, diaphysis. And when the fracture does not extend the entire width of the diaphysis, we call it an incomplete fracture. There are examples of this, such as Taurus fractures. Those are of the distal radius in small children. Green stick fractures, which usually happen in the mid-shaft of a bone, typically in the forearm, radius, and ulna. We fall. Kids fall too. And so humans, we just fall, right? Cats don't fall that much. Why don't cats fall? Why don't cats fall? They land on their feet always, right? They have 4 legs they get to stand on, right? We have 2. Basically, our walking is just controlled falling, right? Think about how you walk, right? You hang a foot out in front of you, and you just fall forward until you land on that foot. Then you hang another foot out in front of you, and you fall forward until you land on that foot, right? The whole time keeping your body over your center of mass, right? You're doing a controlled fall, right? That's why babies aren't born immediately able to walk. Cats can walk shortly after being born. It takes a couple of days or something like that. It doesn't take very long at all, right? It takes kids like a year to learn how to walk because it's a controlled fall is what it is, okay? So we fall. Humans fall a lot because of just how we're designed. We're bipedal. That gives us a lot of advantages, but it gives us disadvantages, such as if you happen to get one foot caught on something as you're taking a step, right, you're pretty much going to go to the ground, okay? And children are goofy. Children got, their body parts aren't, sized correctly in relationship to the rest of them, and they tend to fall. So these types of fractures, Taurus, green stick, and plastic fractures, are all fractures describing pediatric trauma, okay? When adults fall, adults tend to do a really good job at breaking their bones. Like if they either don't do anything or they do a really good job of fracturing their bone and they get complete fractures. When children fall, because their bones are effectively a little more bendy, they have ossified less. We adults have our skeletons have ossified. They've hardened up. Children haven't done that yet, so their bones are a little more plastic. Now, plastic in this case means flexible. Okay. So, Taurus fractures, green stick fractures, and plastic fractures are all fractures where the bone isn't actually broken all the way through. Okay. A green stick fracture. If you guys haven't heard of this before, a stick, a limb taken off of a tree, a bendy limb taken off of a tree immediately and then tried to bend, right? That stick is still green, right? We say the stick is green because the stick is alive. The part of the tree was alive before you took it off. And when you bend those, they're usually pretty bendy, right? You can kind of bend them to a point where the outside of the bend begins to break, right? Fracture. But the inside of that bend doesn't fracture, okay? That's what we would call a green stick fracture in a child, where one side of the bone appears to break and the other side of the bone doesn't because the bone was bent. Plastic fractures are the same kind of thing where the bone bends but doesn't fracture on either side. Right? The bone is actually bent in its appearance but isn't broken on either side. That's a plastic fracture. So green stick and plastic fractures are fairly similar. Green stick fractures, you actually see a break in one side of the bone, whereas plastic fractures, the bone is just bent, and you don't actually see any actual break. Yeah.
How are plastic fractures treated?
Often they're just splinted and we let them regrow. There's no fracture to replace.
But they can heal in that curved space, right?
Yeah. I mean, I haven't seen a plastic fracture severe enough where they would have to go and do any kind of surgical intervention. It happened and then we let them heal. Yeah. And often it's not going to cause a major change in things like the length of the bone because it's not happening near one of the growth centers at either ends of the bone. So it just changes the way the bone shape. Now, when I do this, I'm largely over exaggerating how much bend you'll see in a plastic fracture. These bends are often significantly less. And when they happen in very young children, the bones have so much growing to do where everything kind of just realigns itself. Yeah. So not much treatment except for splinting or casting for a period of time to immobilize the body part to kind of just let it correct itself. Good. Our next terms. These are terms for complete fractures that either are closed or open, but completely fractured. Transverse fractures. The fracture fragment runs horizontal to the ground, or said in another way, the fracture fragments, the fracture is perpendicular to the long axis of the bone. So if the bone goes this way, the fracture runs right across the bone. Oblique fractures are fractures where the fracture happens at an angle. Okay. Transverse and oblique fractures typically come when sort of axial pressure, axial load is put on the bone, kind of like I was doing with my pen, right? You get your foot stuck in something and then you fall over, right? That can cause transverse or oblique fractures. Spiral fractures happen when there is a twist associated with the mechanism. Right? So they got one end of a body part stuck, right, and the rest of the body twisted. Instead of bending, it twisted. That causes a fracture that runs sort of like a spiral around the bone. These fractures that are complete fractures, there are only two fracture pieces. There is one end and the other end. Importantly, there are not many small fragments. Okay. Comminution is when there are many small fragments for the fracture. So we call these comminuted fractures. Two or more fracture fragments. These often happen from blunt force trauma. Like somebody gets hit with something, like they get in a car accident, or they get hit by a car, or motorcycle accident, or someone gets hit with a baseball bat, or something like that, right? Something runs into their body part, or they run themselves into something, right? These are usually higher energy mechanisms, higher energy mechanisms, and they make many small fracture fragments. It is more difficult, if there's surgical intervention required, it will be more difficult to realign the fracture fragments. And in fact, some of these fracture fragments may have to be removed and allow the bone to just regrow. There are different terms, segmented, butterfly, or splintered. But the important thing to remember is comminuted fractures are when there are many small pieces. All right, I have a few more fracture types to describe. These are some of the common ones. Impacted fractures. Impacted fractures happen when the bone is weak enough to where the bone, when the fracture happens, the bone can be driven into the other end of bone. It can be smushed together. This often happens to the distal radius, which is why it's shown here. So there's the distal radius. The patient's 65-year-old female, and she happens to fall. Sticks her arm out to stop her fall. Okay. It can fracture in a couple of different ways. One of the ways I'll show you on the next slide, but this one happens to be an impacted fracture, where instead of fracturing and angulating either forward or backward, the fracture fragment just drove into the other fracture fragment. They smushed together. Okay, to use a technical term, they smushed together. They are impacted against each other. Okay, one fracture fragment driven into the other. This often happens when the bone is weak. Okay, such as conditions like osteoporosis or osteopenia, which is like osteoporosis but not as severe. But the bone has been weakened. That's most common. Or the trauma was pretty significant. The mechanism was very severe. But I see this a lot with, the reason why I gave you an example of an older woman is because women tend to have more problems with osteoporosis, brittle bones, than men do. Men got all their own issues, but women tend to have this issue with osteoporosis. So when they fall, outstretched hand, fracture fragments can be driven into each other.
We're gonna have more issues with bunions too.
Yeah, but hallux valgus bunions. Yeah, so there's a number of things that women deal with, that, of course, that men don't, and there's a number of things that men deal with that women don't. And there's commonalities for depending on sex, of course. Again, totally generality, or general ideas, right? Everyone's an individual, but we see some typical things. Okay, the next the next one specifically is called a Caulis fracture. You got to remember this one. It shows up on lots of tests when it asks about trauma. Okay, so the state board will ask you questions on this. This is just a type of fracture that's so common we just have to know about it. It's called a Caulis fracture. They diagnosed these types of fractures before we had X-rays. Before 1890, people were breaking their bones before 1895. Okay, before we had our first X-rays. They've had names for these these types of fractures for a long time. Okay, before we were able to actually image them. A Caulis fracture is a fracture where the distal radius fractures and displaces posteriorly. That's the important part of this. Posterior displacement of the distal radius. The ulna can fracture in a Caulis fracture, but doesn't have to. So they can leave their ulna intact, but fracture their distal radius. Most often these are closed fractures, but in significant mechanisms of injury, these can become open fractures. Anything can become an open fracture if the mechanism is severe enough. Okay, but what they'll have is they'll have this sort of deformity, almost like a dinner fork deformity to their forearm, where it'll go here and then it'll raise up and out. This whole part of their arm will be shifted up, or in all actuality, it's shifted posteriorly because of anatomic position. The opposite of this is called a Smith's fracture, where there is anterior displacement of the distal radius. That's what they're asking about, a reverse Caulis or Smith's fracture. All right, let's look at our next couple. I've only seen one or two of these ever. They're called the Montagia's fracture. It's a fracture of the proximal ulna with dislocation of the radial head. So the radial head doesn't fracture, it just dislocates. The ulna is what's providing the stability for the proximal forearm. The distal forearm is stabilized by the radius, but the proximal forearm is stabilized by the ulna. If the ulna fractures proximally, up here the forearm is no longer stable and the radial head can be dislocated. Okay, so that's a Montagia's fracture. There's the obvious fracture fragment. Potts fractures are a bad kind of fracture because they make the ankle joint unstable. Okay, now what is the word malleolus? They use the word malleolus in there. What's that?
That's the bones underneath the tibia.
Yeah, and fibula, right? So you reach down to your ankle and you feel your ankle. Those ankle bumps that you got, those are called malleoli for plural, and each one's a malleolus. You got one on the inside, one on the outside. So we have a medial malleolus and a lateral malleolus. Okay. Potts fractures are an ankle fracture of the distal fibula. So the distal fibula is fractured here. The lateral malleolus is fractured with a fracture of the medial malleolus. Even if they don't fracture the medial malleolus, the ligament, I believe it's the deltoid ligament between the talus and the medial malleolus is severed, is broken, ruptured, sprained. And what that makes is it makes it for an unstable ankle joint. Okay. Now, this type of fracture where both malleoli are fractured is called a bimalleolar fracture. You can have a single malleolus on the left or right fractured and still have a stable ankle joint, but if both of them fracture, you do not have a stable ankle joint anymore. Okay? They're not going to walk on it if they have any fracture, but importantly, they need surgical correction if they have a bimalleolar fracture. You should know that there is a third malleolus to the ankle. So if you ever hear of a doctor talking about a trimalleolar fracture, somebody got really messed up. But importantly, they fractured their third malleolus, which is on the posterior tibia. I'm not going to go get out the skeleton, but in the back of the tibia, on the posterior of the distal tibia, there's a third malleolus that supports the ankle from behind. Okay, and that could fracture as well. But importantly, Potts fractures, a fracture of the distal fibula where the laser pointer is showing, often with associated medial malleolus fracture. Okay. We've got a couple more terms to get out, so those are more specific. Those terms, Caulis, Montagias, and Potts, those are specific to exactly those body parts. Okay, the rest of these are just terms, right? Stellate fracture. A stellate fracture is any time a fracture fragment has a star-like appearance. We often call them burst fractures too. The fracture lines radiate from a center point of injury. You know, this person tripped and fell directly to their patella, okay, and the patella burst, okay. It's actually happened to my brother. He was on his way to go get knee surgery, walking to the surgical center, and happened to fall, and had a fracture of his patella. Yeah, he had to get his patella wired back together. And yeah, not a fun time for him. But importantly, it got corrected, and he was in the right place for that to happen. He was just outside the surgery center. Tuft fractures. So you have your fingers, right, and your toes. The ends of your fingers, the bone at the very end, the little bone at the very end, is called the distal phalanx. Okay, you have them on your toes, you have them on your hands, distal phalanx. The end of the distal phalanx is called the tuft. Okay, so a fracture of the very tip of the bone at the end of your fingers or toes is called a tuft fracture. This often happens when people get that body part like smashed by something, like you're hammering and you accidentally hammer your finger, or you get your finger smushed in a door, stuff like that. It's very common to see tuft fractures. But they're comminuted because usually the mechanism is pretty high, like a hammer smushing it, and they are of the distal phalanx. Lastly, if I can get to it, lastly, compression fractures. Compression fractures are typical in the vertebrae, and these are where there is a load put on the vertebra, like you fell off of a roof or something like that. And instead of the vertebra shifting anteriorly, dislocating, shifting posteriorly, dislocating, or shifting left and right and dislocating, or subluxing, the load is so much that the vertebrae just smooshes. Okay, so what is normally a block-shaped vertebra turns into a wedge shape. And that wedge shape can be clearly seen on an X-ray, and we can diagnose compression fracture based on that. So vertebral body collapses or is crushed. And again, it's more common when there's a high mechanism, such as a motor vehicle accident or a fall from a height. Fall off a ladder, fall off a roof, stuff like that.
So compression fractures are just vertebrae fractures, right?
I mean, in principle, you could compress other body parts, but this only really happens to the vertebrae.
Like the other picture where it showed basically where you're saying that if people have osteoporosis, osteopenia,
Yeah.
fracture of the...
Impacted fractures are a lot. Oh, hang on, right here. Impacted fractures are a lot like compression fractures. Impacted fractures, though, you can actually clearly see where the fracture is. Compression fractures, you won't be able to see the fracture fragments. You'll just be able to see that the shape of the bone has changed, and this is most typical in the vertebrae. So if you're able to see like the bone, the jagged edges to the fracture, we're going to call it an impacted fracture. Yeah. So there you go, compression fractures. All right. We've been talking